Good morning, and welcome to the inaugural live stream of PEMBA On Demand. I'm Norm Chapin, the host of the live stream. The University of Tennessee Haslam College of Business is the proud sponsor of this live stream and the podcast that we will be discussing momentarily. The Physician Executive MBA program, as part of the Haslam College of Business, has been providing a physician leadership symposium for many years for its PEMBA alumni. PEMBA On Demand has been developed to provide education for physician leaders and to bring you the latest and most relevant topics. PEMBA On Demand will provide you these topics in a combination of live streams and both video and audio podcasts. The live streams will be available on this YouTube channel, PEMBA On Demand. That's PEMBA on-demand, which you can find by looking on youtube.com. The podcast will be released on a bi-weekly basis, and they will be available to you on our website as well as in your favorite podcast players or listening apps such as Apple Podcasts, Google Podcasts, Spotify, Overcast, Stitcher, and Podcast Addict, for example. Each live stream and podcast will focus upon an aspect of leadership, innovation, career development, or the business of medicine. We hope that you'll take full advantage of these practical, insightful, and relevant discussions designed to help physician leaders get new and build upon existing leadership skills and perspectives. PEMBA On Demand will allow you to be an even bigger force for good in healthcare. CME will be available for these products, for these contents, and the live streams as well as the podcast. You can visit tiny.utk.edu/PEMBA On Demand to obtain your CME certificate and information about how to register for the CME hours and credits. Our inaugural show, Entrepreneurship in Telemedicine, focuses on an area in healthcare that has seen tremendous growth in recent years. Really, ever since the COVID pandemic, telemedicine and virtual visits have achieved a level of penetration into the market that we had not seen previously. As of 2019, the telemedicine global market was valued at about 40 to 50 billion US dollars. The market was forecast to grow significantly in the future. It's now projected to be valued at nearly 460 billion US dollars by 2030. According to some recently published data, over 80% of consumers have used telemedicine at least once. 76% of people the age of 55 or over have used telemedicine, and 74% of millennials actually prefer telehealth visits to in-person doctor exams. 73% of people, even who live in rural areas where you would think access might be more challenging, use telemedicine and virtual visits. Patients are reported to prefer using telemedicine for prescription management and to receive care for minor illnesses. The Veterans Affairs has administered over 2.29 million telemedicine interactions to over 782,000 different veterans, and 96% of telepsychiatry patients are very, very satisfied with their virtual mental health care. Our two guests today are both involved in telemedicine, telehealth market sector of healthcare. They will be presenting their vision and aspirations for utilizing telemedicine in their practices and discuss their reasons for innovating in this rapidly growing sector of healthcare. I'm very pleased to introduce our first guest to the inaugural live stream, Dr. Rinku Mehra. Dr. Mehra is an alumnus of the University of Tennessee's PEMBA program, graduating with the most recent class in 2022. Dr. Mehra is a board-certified pediatric endocrinologist and obesity medicine specialist. She was raised in Northern Virginia, where she currently practices, but she also sees patients in her practice from Maryland, Florida, and Iowa. Dr. Mehra graduated from the University of Virginia Medical School and then completed a pediatric residency at Rush University Medical Center in Chicago. After her residency, she then graduated from a pediatric endocrinology fellowship at the University of Iowa. Dr. Mehra has been treating patients in Northern Virginia for over the past 15 years. Dr. Mehra is also the founder and CEO of the Mehra Clinic. She has a great deal to share with us today about her innovations using telemedicine and the advantages that it is providing for her and her patients. Dr. Mehra, welcome to Pemba On Demand.
Thank you so much. Thank you for having me here.
Well, we're excited to have you here. I'm very much looking forward to your presentation and the information that you have to share with us.
Thank you so much. Happy to talk to you about my experience at Pemba and beyond.
Great. Well, I'll bring your presentation up on the scene here, the screen, and then you'll be all set to go.
Okay, thank you. So I wanted to first introduce myself. So my name is Rinku Mehra. I'm a pediatric endocrinologist, and I'm currently practicing in the Northern Virginia, DC metro area. I'm originally from the DC metro area, and I did my training out in Chicago at Rush University for pediatrics, and then I did my pediatric endocrinology fellowship at the University of Iowa. Next slide, please. So I am a pediatric endocrinologist. I'm also a pediatric obesity medicine specialist. And I've worked throughout my career, I worked in academics. I also worked at the FDA. And then I was a medical director for a large multi-specialty pediatric endocrinology group in Northern Virginia. I also worked in the payer space. So I've been a medical director in Anthem Medicaid, and then also at Aetna in the commercial space. And most recently, as of January of this year, I started my direct specialty care pediatric endocrinology practice. Next slide, please. And so how I got here really was, like I said, I started my practice shortly after fellowship in 2008. I was an assistant professor at a large academic center, and I realized that very quickly that seeing a patient every 15 minutes, especially a patient with type 1 diabetes, was very, very difficult. And what I wanted to do was really take time to provide more education. And as an immigrant myself, I realized that it does take time and a lot of patience to explain to families what they need with regards to understanding their health. I've also taken time to understand the insurance model of care and reimbursement policies. And I've also always wanted to reach a broader audience and affect larger populations. And that's really, how I got to where I am now. Next slide, please. What I've always wanted really is innovation, improving health outcomes, and then really expanding and reaching larger audiences. And in 2022, I joined Pemba, the Haslam College of Business graduate program, and obtained my MBA. And that really led me to where I am right now in my career. Next slide, please. So I am the CEO and founder of the Mehra Clinic, which is a pediatric endocrinology direct specialty care practice. It is also a telemedicine practice, and I see patients right now in 4 different states. So I see patients in Virginia, Maryland, Iowa, and Florida. Next slide, please. And what I want to talk about today is really my mission and the problems and opportunities that I saw. And I really developed these throughout my training and education at the Haslam College of Business. Next slide, please. So like I said, my clinic is a pediatric telemedicine clinic. I do offer in-person visits as well in Virginia, where I'm located. And I really focused on increasing access to care to pediatric endocrinology or for pediatric endocrinology patients in Virginia, Maryland, Iowa, and Florida. Next slide, please. Next slide. The problems that I encountered were that really there is a lack of access across the country to pediatric subspecialists. There are very few pediatric subspecialists that participate in this type of practice, in particular managing children with diabetes, growth problems, thyroid disorders, and pubertal concerns. And patients are often having to travel to large academic centers to get the type of care that they need. There's also a lack of patient satisfaction. I myself was seeing patients every 15 minutes and really didn't have time to devote to my patients, and patients sense that. And as a result, there's often lack of patient knowledge or understanding about their disease process and how to manage themselves, especially for chronic illness. Next slide, please. Um, with the COVID-19 pandemic, there was an increased adoption of telemedicine services across the country to increase access to care. And it has since been adopted by parents and adolescents as well as college students. In fact, multiple studies have showed that patients prefer telemedicine over in-person visits as it saves them time and improves their access to their provider. Multiple states since the COVID-19 pandemic had also changed their telemedicine laws to allow practitioners to practice across state lines, and there was lack of patient satisfaction with the current traditional healthcare delivery system. Next slide, please. And so when I looked across the US and I did a market analysis, I really found that the average wait time to see a pediatric endocrinologist was anywhere from 3 months to 6 months. And all of the practices across the country, whether they were private practice or academic centers, all required referrals from the primary care doctors. In fact, I even called the pediatric endocrinologist practice near my home where I used to practice yesterday, and I found out that there currently is a wait list in March, and they're not accepting patients at all. They're just asking their patients to put themselves on a wait list to be seen. And so really, this is across the country what we're seeing. Next slide, please. There's a lack of patient satisfaction with the current healthcare environment. So we typically see patients as pediatric endocrinologists in practice every 20 to 30 minutes. And this is due to the need for increased volume due to decreased insurance reimbursement. And there is always a need for a referral, and often insurance restrictions based on who can be seen and what type of care we can provide. Next slide, please. From a patient perspective, there's often a lack of understanding of the diagnosis and the treatment. So patients come in, they're usually in and out of a room within 10 to 15 minutes. By the time they're checked in by the MA and put in and see the doctor, really they spend maybe 5 to 10 minutes total, and they really don't understand their diagnosis. Often I found that my patients were Googling things that they didn't understand in the office. Not to mention, after the visit, there was no direct access to the physician. And so they were having to call multiple times to ask questions, or in the case of diabetes, we're not really understanding what to do if they were ill, if their blood sugars were high, if their blood sugars were low, often leading to a lot of after-hours phone calls and pages to the on-call endocrinologist. And this also led to physician burnout. Next slide, please. So based on the observations of the market, I decided to propose a solution to the problems that I saw. Next slide, please. So in terms of lack of access, like I said, 3 to 6 month wait on average to see a pediatric endocrinologist, I decided to tailor my practice to one that does not require any referrals. There were no insurance restrictions. The patients could pay as they went, or they could pay in a subscription model, so a monthly fee where they would have access to my care at all times. And I really wanted to have a goal that they would have their questions answered within 24 hours and to have the same day, next day, or same week appointments. And I really wanted to offer telemedicine in multiple states and in-person options as needed. Next slide, please. My appointments, telemedicine and in person, are 1 hour for new patients, and I have about 30 to 45 minutes for follow-ups. My treatment options are tailored to each individual patient, so there's no cookie cutter approach, and I really approach the individual patient with regards to what their needs, desires, and anxiety is really. And often these patients do have a lot of anxiety, really because they don't understand fully what their diagnosis means and what the long-term outcomes are. And I really strive to focus on that. Next slide, please. My patient appointments, like I said, are 1 hour. I coach them on next steps I often make an appointment with them within 2 to 3 weeks to discuss their lab results. So I don't leave that to chance and say, okay, I'll call you when I have the lab results available. I make an appointment for them each visit. They have an appointment scheduled within 2 to 3 weeks to discuss their labs and next steps. They also have access to me via text and email. And then I offer social media campaigns to offer more patient education. Next slide, please. So the first phase was to start with telemedicine services for pediatric endocrinology care in the state of Virginia. And then my next phase was to expand to Maryland and Florida, which I've already done that. And my third phase was to expand to Iowa and other states that allowed telehealth across state lines. And finally, to add other physicians as needed. Next slide, please. Next slide, please. So really, in conclusion, what I wanted to do was provide pediatric endocrine care from the comfort of the patient home. Next slide, please. I wanted to improve access to care and increase patient satisfaction, and really focus on providing evidence-based care based on the Pediatric Endocrine Society, and American Board of Obesity Medicine guidelines, in addition to the ADA guidelines. Next slide, please. And I think that's the end of my presentation.
Great. Thank you very much. I appreciate you taking the time to give us such a thorough presentation about your practice. I think that was great. And it did raise a lot of questions in my mind. So I thought maybe if you were agreeable, we'd talk about a little bit more about some of the aspects of your current practice and the role and that type of thing.
Sure. Yes, absolutely.
Great. The first question that came to my mind is what were the primary motivations for you to embark down the path of concierge medicine or direct primary care? You obviously practiced in a more traditional model for quite some time.
Yeah, so the reality is that I've always wanted to reach a broader audience. And I think I was very dissatisfied with the current state of healthcare and the state of care that I myself was delivering to my patients. I knew that if I had just, spent maybe even 10 to 15 minutes more with each patient, I could probably deliver better care for them, educate them, and really teach them about how to manage their disease. But I didn't have the time to do that in traditional practice. I was really seeing, patients every 10 to 15 minutes. I actually really, when I was in practice in my private practice setting, I realized that I did have a significant amount of burnout in the job, to the point that I thought I didn't want to practice medicine at all anymore, like clinical medicine. I wanted to do something different. And that's part of the reason that I left the practice and went to DC Medicaid, was because, again, I said I wanted to, practice in reach a broader population of patients, reach a larger audience. And then I think needed a break from the clinical practice and everything that went along with it. I think ultimately when I did my MBA and talked to my colleagues at the MBA program, I went into the program thinking I would want to do something in corporate medicine or, go higher in the insurance world with regards to care, how we manage care. But when I went to the MBA program at Haslam, most of my colleagues were asking me questions about pediatric endocrinology. And I realized that I still loved the science behind pediatric endocrinology. I really loved taking their questions and educating even my fellow colleagues about pediatric endocrinology. And I started thinking, maybe this should be just a trial for me to see if I can do it, if I can actually develop a care delivery model that I would be satisfied with and that would help patients. So I think I wasn't ever done with clinical medicine. It was just the way that I was delivering the care that I didn't want to do anymore.
And how long were you out of clinical medicine before you transitioned back into this model?
So when I left my practice in 2020, I left in 2020 right at the height of the pandemic, and I was still doing virtual care for the old practice. So for the entire year afterwards, I was doing a polycystic ovarian syndrome telemedicine practice with the old group. with a pediatric gynecologist. And during that time, I actually saw that my patients who I had seen in practice were now embracing telemedicine. And in fact, our no-show rates were 0 for telemedicine, whereas when they were in person, it was a 50% no-show rate. And so I really saw that these adolescent girls were coming in, adolescent and college girls were dialing in, sometimes as early as 7 in the morning before school started so they could get into their visits. And I saw that that was a model of care that I had always wanted to do, but we were so limited by insurance restrictions. And with the COVID-19 pandemic, those had been lifted. And so when I started seeing, some of those things, I thought, well, it would be nice if I could do this on my own outside of the clinical, practice setting. So I really wasn't out of practice for that long because I was doing, part-time work with the practice. I still took call for the old practice 1 weekend a month, mainly because I was the medical director of the practice and I had a hard time letting go, and I wanted to help my colleagues. And they were not going to be able to hire somebody. In fact, it's 4 years later, they still have not hired anybody at all. And so there's a significant shortage of pediatric endocrinologists across the country. So I really wasn't out of practice for that long, but probably fully maybe about a year and a half that I didn't see patients while I was trying to develop this model of care.
And now that you've started up the Mehra Clinic, are you still helping out the practice at all?
No, I'm not
Okay.
anymore. I mean, I'm too busy in this practice to do it.
Now,
But they have about a 4 to 6 month wait still to have patients come in.
so was your uh, primary your ovarian care practice the cystic ovarian disease that you were working with, polycystic ovarian disease? Was that
Yes.
your first foray into telemedicine, or had you been using it in the clinic for other patient populations?
Yeah, so my goal when I was the medical director of the pediatric endocrinology practice was to do diabetes care virtually. So I had been begging the administration to do virtual visits for diabetes care for many, many years. And we knew that diabetes care, there's many studies across the country that showed that care for diabetes could be done virtually. The patients come every 3 months to a pediatric endocrinology office. They take time off of school. Their parents take time off of work. They're missing often whole days of school to come in to see the doctor. And all I was doing at the visit was really all I had time for was looking at their blood sugars and making insulin dose adjustments. And that could easily be done from telemedicine. And in fact, I would have probably had more time to see them telemedicine because I wouldn't have to have the MA check them in and then bring them back to the room and do their blood pressure, height, weight, which takes another 10 minutes. And so I was begging the administration to do that, but we had a lot of laws before the COVID-19 pandemic with regards to billing and site of service that we could not utilize that care. And so right at the start of the COVID-19 pandemic, we said, let's just do this. In fact, I was the telemedicine director of my practice because I really was thinking that this is the direction I wanted to go before the COVID-19 pandemic, but we weren't making any headway at all. We had probably seen one patient in a year via telemedicine, and we saw them for free, and weren't able to bill for it. So there were a lot of restrictions. But the PCOS clinic we did really right when COVID hit, we were geared up to do telemedicine, and we were able to bill for it. And I was able to see them from my home, and they were in their home, and we could bill for those visits. And that's really how it started.
Can you tell us a little bit about the difference between your financial model in your concierge practice, your direct primary care practice, versus the practice that you had when you were in the clinic setting in the group?
Right. So I don't now, because I practice across state lines, I don't have insurance that I take for my visit itself. So my consultation fee is direct care to the patient, meaning they pay me directly. They use their FSA or HSA, or they just pay, their fees. But then I provide a super bill for them with all my codes, and they get reimbursed by their insurance depending on what their out-of-network rates are.
Are there a large
So I don't have a
percentage of
limitation.
are there a large percentage of insurance companies that will pay that out of network fee for your services?
There are several insurances that will pay out of network. I don't know what, off the top of my head what the rates are, but sometimes they're anywhere from 50% to 80%, depending on what the each individual person has for their out-of-network coverage. Not to mention that they have deductible, some of them have high deductible plans, so they sort of have to meet their deductible before. That being said, when I was in a traditional practice, I often had no idea what my visits, what charges were being collected for my visits. I would see the patients. I had no idea. The only way I found out one time was that I looked at a review. I looked at myself online, a review, and somebody had reviewed me very poorly in my old practice. And it wasn't for the care that I delivered. It was because they were charged $650 for my visit fee. And they had paid a copay and they had thought their insurance was covering it. And then the practice billed them $650. And at that point, I realized that, it may not be very different. And there's a lot of hidden healthcare costs that we as patients and as doctors also are not aware of for our patients. So I could see a patient, with an insurance-based model, they pay a $25 or $30 copay, and then their insurance, has certain things that they won't pay for, or they have to meet a deductible, and so they bill the patient anyways. And so I really wanted my model of care to be very transparent, like my pricing is very transparent. And I'm in the process right now of having laboratories bill me, so LabCorp Quest or Sunrise bill me, and with a direct care model, we can actually get lower lab rates, lab cost for our patients, because sometimes patients are paying exorbitant amount of fees for labs as well. But I really wanted a model where patients knew exactly what they were paying for upfront, and without any hidden fees. And I think that's also what direct care offers.
So do you pass those costs, those lower costs through to the patients, or is it considered part of
Yes.
the package?
No. So we pass on those lower cost savings onto the patient as well.
Do you have any kind of similar arrangement as it relates to medication costs, which is another huge burden on a lot of patients?
Right. I don't. So some direct care practices do, and they're allowed to have in-house pharmacies. The state of Virginia, it's very complicated to do that. So I don't have an in-house pharmacy, and I don't plan to do that right now. But I do look to see what the cheapest option is for my patients as far as their medications are concerned. As a pediatric endocrinologist, I mean, I think the most expensive medication that I was prescribing in practice was probably insulin, but the insulin, prices have gone down significantly. And now the cost of the medications, such as the weight loss medications like Wegovy or Ozempic or Mounjaro, I mean, those are the highest cost. And unfortunately, I don't have a way to lower the cost if insurance doesn't cover those. But our medications like metformin or thyroid medication are generally not too expensive and those are the typical ones that I use in my practice. I use other medications to stop puberty, and often I will, their insurance will cover those. And so, we usually don't have a large, a high cost for some of the medications other than the weight loss medication.
What what percentage of your practice are from patients within Virginia versus the Maryland, Iowa, and the other states that you have branched out into?
Yeah, so the majority of my patients are in Virginia and Maryland. So I practice in Northern Virginia. I have for many years, and I used to see patients in Maryland as well when I was at the academic center. And so most of the patients are finding me in Virginia and Maryland. I do have patients from Florida as well who have found me. I have patients with diabetes who have found me from Florida. And so I would say, as far as percentage wise, I would say, 10% from Florida. At this point, I probably have a few patients, maybe 10% from Iowa, and then the rest, 80% are from Virginia and Maryland
Mhm.
combination, which really is not too far. I mean, I'm 20 minutes outside the border from Maryland, so people can drive 20 minutes across the border and see me.
What percentage of your patients were patients that followed you from your clinic?
Zero, none.
Really?
None.
You,
Yeah.
okay.
So I had left the practice, and the practice had sent out a letter actually in 2020 when I left, when I, still working part-time, but I had left the position as medical director. And so the practice sent out a letter saying that I was leaving the practice. And so I really started this practice from no patients that followed me. And I, really I didn't have a non-compete because it's been about 4 years, but I really didn't reach out to any of my former patients or let them know that I was, practicing.
One of your one of your interests in starting the practice was resolving access issues and spending more time with patients. I'd be interested to know what feedback you've been getting from the patients that you are seeing, comparing the interaction with you compared to a more traditional model.
So I will say the feedback is it's night and day, to be honest. So spending an hour with a person or with a patient and their family, and then following up with them pretty regularly really allows you to be more involved with the patient and really understand a lot of, their social factors that come into play. I'm really involved with a lot of the, patients who have really lack of understanding of their medical diagnosis. I really can spend that time and delve into it. Not to mention, I do nutrition counseling and education for my patients, almost every single one of them, regardless of what they come in to see me for, because there's a lot of factors a lot of conditions that they have that are directly related to their eating and their lifestyle. And so I have a long time to spend with them. So I have a lot more fun in my clinic with my patients. I've learned a lot from them. I enjoy that patient interaction. And that, it's sort of a double-edged sword because I have found certain disease processes and diagnoses that have been missed sometimes for many years, because not because they saw somebody who was better than me, but it's really because the patients didn't have a physician that had the time to ask them certain questions or really delve into certain lab abnormalities, that I look at really closely now, and I've picked up on things. And it's sometimes very hard because I get very emotionally attached to the patients and their families too. And so it's hard to separate that. Whereas when I was in traditional practice, I was seeing patients, I mean, I didn't even know people's names. And if I saw them at the grocery store, I wouldn't actually know who they were because I had spent such a small amount of time with them, and everybody, was similar as far as what their diagnosis and disease was. And now I know who my patients are. Sometimes they're sending me recipes that they have made, or they're sending me pictures of themselves in their prom dresses and saying, thank you so much for helping us do it, get to, our goal, or, these diabetes patients who haven't had good control for many years and now are understanding things and sending me pictures of themselves and their A1Cs and their CGM readings. And so I have a much more personal relationship with my patients. I really strive to have each patient feel like they're a member of my family. And I also focus on patient advocacy. So I've had patients who have had brain tumors, for example, and we're not able to get in to get in for an MRI for 3 or 4 weeks. And I have to call the, radiology center saying, you need to get them in today. And they do. And so I think seeing it from a patient perspective is also very important for us as physicians to understand what patients go through when they're on the phone on hold, or when they don't understand, what lab tests mean and how much anxiety that causes for patients, for their children. So it's really been very emotionally rewarding, but on the other hand, also, it does allow me it makes me be more involved, and sometimes I think about some of these things a lot more than I did in my previous practice.
So, speaking about that, that involvement can sometimes have a double-edged sword to it, or have a double-edged sword
Yes.
effect. What is your current time commitment and the access that the patients have to you? How do you maintain a work-life balance with the advocacy and the obviously the amount of personal involvement that you have with your patients?
So I take a much smaller load of patients. And so I think my goal is, to be honest, no more than 200 patients total.
Hmm.
And I'm almost halfway there, and I started in January. So, I think that's my limiting factor is I really want to provide I want to provide quality care, and I have to limit the number of patients that I see. That being said, not every patient, wants to pay for the services, and I'm fine with that. And so I had a hard time in the beginning setting boundaries, but I do say, it's Monday through Friday, 9 to 5. Really, if it's an emergency, then of course I respond to it. But otherwise, 9 to 5, no weekends at this point. And I really try to get everything taken care of before, the end of the business day. Now, that being said, um, if there is obviously an emergency or something, then I do have, partnerships with local pediatricians. So if there's an emergency, they couldn't go to the emergency room, they go to their local ER. But patients in this model actually are very respectful of the doctor's time. And I don't have people abusing the system at all. In fact, most of the time they're very apologetic, saying, "We're very sorry to have bothered you, but we just had a question about this." And usually it's not anything super complicated. But they're very respectful of my time, and they know that I'm available, and they know that I'll get back to them. And I think that decreases their anxiety also.
So how do you mentioned social media in your presentation, and
Hmm.
I'd be interested to know what you have found to be the most effective way to market your services, and also what is the most effective way for patients to contact you in synchronous ways, or do you use more asynchronous communication with them like texting or emails?
Yeah, so I use all of those. So social media I found has been helpful. So the biggest thing about social media, I will say, is that I didn't want to do it at all. Like I never wanted to do social media. And I think we as physicians in general are not comfortable with social media. We when I was in practice, I mean, it was a no, no, like just don't put yourself on social media, don't do anything. But um, but what I found is that there's a lot of quote unquote influencers that are not physicians, they're not in healthcare, and they are saying they're spreading a lot of misinformation to our medical community that is just wrong and sometimes dangerous. And I felt like, I mean, part of a large physician community that really advocates for social media use, with evidence-based information. And there's a lot of us who are just starting to really provide evidence-based information. We provide society guidelines and really talk to the patients in a way that they are comfortable with. I mean, a lot of people, I think their statistics are that Instagram and Facebook are still the two most heavily used social media platforms by patients and families. I even started, being on TikTok because these, adolescents are all on TikTok, and they have a lot of misinformation that they are getting from TikTok. And my goal really was to educate and empower patients. It's always been that. And then to do it in a platform that they're comfortable in. And that's what I've found has been the benefit of social media. Um, what I talk about on social media is very common things. A lot of it is on nutrition. Um, I talk a lot about PCOS because that's been a passion of mine. I talk, about thyroid disease and things that are related to pediatric endocrinology and diabetes and obesity. I put recipes on there, and so things that are helpful for my patients, but engaging as well. And I think that is another way to spread education that patients need, because they're going to get it from somewhere. So they might as well get it from a reputable source.
Was there a special, I mean, how did you get comfortable with social media? Is this something, what approach did you take?
I don't know if I should say it on your podcast, what approach I took, but it is, um, I am still not comfortable fully with social media, so I'll just put it out there. So it's just something that I force myself to do. And I had somebody um, I had a marketing expert actually help me get comfortable with social media. And she really forced me to say things. I'm still not fully comfortable with it, but I think I've gotten more comfortable as I do it more and more. So,
And how often do you release something onto Instagram or Facebook? Do you have a regular schedule, or
yeah,
are you just,
so I have an assistant now that helps me. So I was doing a lot of it on my own. And I did a lot of it for myself, by myself for about 6 months. And then I just, with the practice getting busier, I just don't have the time to do that. So I have an assistant now, and she has a calendar. We talk about it weekly about what month we're going, for each month, what we're going to do. So October was, discussion about Halloween, and we talked a lot about endocrine related things related and diabetes related things related to Halloween. And then November is Diabetes Awareness Month. So we're going to talk a lot about diabetes. And so we really have a theme each month. And I do reels sometimes, Instagram reels. If I think I have something to say, or if there's something new out in the news that I want people to know about, then I will say it on the posts. But it still takes a lot to be comfortable on that platform.
And how long have you been on those platforms? When did you start creating the
I think
social
I
media
started
presence?
January, I would say. So just earlier this year.
Okay. Well, that's great. It's interesting. I think a lot of people have the same discomfiture with putting themselves out on social media. It's not a platform that a lot of physicians, at least in my age group, um, have been really comfortable with. So it's interesting to hear how you're using it, and it sounds like you're getting a great response from your patients on it.
Yeah, I mean, I'm very surprised. I was very surprised that, people are actually interested in looking. And I did put out, I had a marketing expert, like I told you, help me with the very first one. And I was terrified to do it. And then she made me say a couple things and posted it. And I think I had like over 1 million views on it. And I was shocked, honestly. I was shocked that, I said, a couple things about things I don't do as a pediatric endocrinologist. Like I don't bring juice in the home, or I don't, bring sugary treats in the home. And people were really mad about some of those statements that I made. And I think that's how it got over 1 million views, because people were saying I was a bad mom and a bad parent, and I don't let my kids have juice. And I think it sort of just spun from there to say, well, I got more ideas of, well, what do you drink then? And so I started talking about that. Like I just offer water and milk. And then there was, a lot of questions that came from that, from parents saying, well, what kind of milk and how much? And so some of it sort of just spewed from there. And I think a lot of it, I take some of these comments that people have and realize that there's a lot of information that people don't have. And so what ended up happening is people didn't even know the right parents also, and I didn't either as a parent, know um, what's the right portion of food to give to a child, and how much activity should they do. And so as a result of that, I actually created a course. So I have like a 42 module online course that I created for parents to talk about nutrition, diet, exercise, hormone conditions. And that really, the idea, a lot of it spurred from social media use, because I was seeing a lot of people asking the same types of questions over and over again.
That's great. That's a great example of how you can address a need that you might not have even identified at the beginning of this journey.
Right,
That's fascinating. So
right.
I wondered if you'd mind if we kind of talked a little bit about your decision to pursue an MBA and how you think that has impacted this entrepreneurial journey that you're on.
I think it was life changing. I mean, it was really life changing. For me, I was at the crossroads. I think I was in practice for many years. I didn't really know the direction I wanted to go. I told you I was the medical director of my practice. I was overseeing 6 or 7 other pediatric endocrinologists and a team of nurses and MAs. And I was kind of bored, to be honest. And I wasn't satisfied with the type of care I was providing. And every time I would say, I want to do this, for example, do telemedicine in the practice, or um, serve on XYZ committee, or do something, it was always a no. Like, we don't have money for that, or we can't do this, or we can't do that. I think it was many years that I, had that built up frustration. And I just felt like I wasn't delivering care the way I wanted to. I often doubted my own ability as a physician. And I think that's very common if you talk to women. Women have a lot of imposter syndrome, and maybe men too. But I really felt like I had that. And I left the practice thinking I'm not going to come back. I had a really hard time leaving because I enjoyed my colleagues, and I had been there for 9 years, and I was very, comfortable. But I just thought I needed to do something different. And I left and went into the corporate world and went to Medicaid thinking I wanted to serve the Medicaid population. I'm an immigrant myself. I wanted to serve, lower income families and really make a difference in healthcare overall. And I went to the MBA. I did the MBA program because I didn't understand the business side of medicine at all. And I was in a lot of corporate meetings where people were putting up spreadsheets and talking about, the cost savings and how much, healthcare costs. And I was like, I don't understand any of this. I just need to go and learn about this. And I was at the crossroads of, do I want to do an MPH and really serve, the public health community, or do I want to do an MBA? And I think I told you before, at one point, I thought I would do both programs at the same time because I couldn't decide which one to do. And ultimately, I decided to do the MBA. It was a shorter program, and I thought, I could learn the business side of medicine. There was some health policy that I could get. And I pursued the education at Haslam. And while I was there, at the beginning, I thought, let me just, understand medicine so that when I go back to work, I can understand, what these business people are talking about. And as I was in the program, my colleague kept saying, and while I was there, I was just sort of coming out of this burnout phase too, and thinking that I just wasn't good enough and wasn't, good enough as a physician and as a pediatric endocrinologist. And I had picked this wrong specialty. I used to think that all the time. I picked the wrong specialty. I'm just not happy in the specialty. And while I was there, all my colleagues at the program said, "Oh, wow, you're a pediatric endocrinologist. Like, we need you. We need you. We need you in Iowa. We need you in Missouri. We need you in this state." And I was like, "Wow, why do they need me?" Like, there's got to be people there. And and I ended up talking to them and consulting for a lot of my, physician colleagues about pediatric endocrinology cases. And really through the mentorship of the program, we had to do a final project at the end of the year to present. And I thought, well, let me just come up with a business plan and see what happens. I mean, I'm not going to do this. I'm not going to go back to pediatric endocrinology ever and practice. And as I was going through the process and doing all of my assignments in the program, really related to building a direct care practice, not to mention there were several people in the program already who were doing direct primary care, and I thought it was fascinating how they had built built their own program and expanded and reached patients. And so I started, researching that more, and ultimately at the end of the year, I had a business plan for this project or for this practice. And Don Leiter was my mentor, and he said, "Why don't you just launch this? Like, just start it and do it and see what happens." And I was like, "Wow, really? Like, are people going to pay me to do this, or am I going to be able to make a living off of this?" And so that's really how it happened. And I sort of gave up the corporate side because I sort of got fed up with like fighting for, on the corporate side of medicine for things that I believed in that just often I was not in control of the ultimate decision in the end. So I think that's, how the practice evolved and started. And still, I still feel like I'm not really sure how this is going to go. I mean, I still have this, doubt moving forward, but I think it is. I'm just taking it one step at a time and moving forward with it.
Well, I can see why you said it's life changing. I mean, it sounds like you were on a very different trajectory when you joined the MBA
Mm-hmm.
program. You had a very different
Mm-hmm.
vision and aspirations at that time. And this kind of brought you back to a very different role that you're now enjoying much more than you were when you were practicing clinically before.
Yeah, and I think that what was really eye-opening to me was that there are so many things that we as physicians can do in healthcare. I mean, I've had many roles outside of just direct, patient care. And I've left clinical practice actually many times. I mean, my husband always tells me, like, "Are you going to leave this again?" Because like I left, I left academics and I went to the FDA, and then I was like, "Oh, I need to go back to clinical medicine." And then I went to, clinical medicine. I went to, corporate, and ultimately kept taking me back to a place of service and serving my patients. And I think that's probably where I belong. I belong, serving patients, but what I do enjoy is that I have a creative outlet. I think the social media piece is a creative outlet for me. And the patient education piece is a creative outlet for me. And the direct care to patients without having to worry about how much am I going to be reimbursed from insurance has also been life changing, because I don't have to, every patient is the same to me. I don't care, if I spend 10 minutes with them or an hour with them, they still have access to me. They still can ask me questions. And so every single patient gets the same level of care. And I don't know if, I would like to think that was the same way when I was in practice, but I don't know if it fully was.
When you chose an MBA program, did you have a sense of certain things, certain structural things or organizational aspects of a program that would fit your work-life balance the best? And were those the factors that led you to choose the University of Tennessee, or were there other factors that led to you coming to Haslam for your executive MBA?
Yeah, so there were a lot of factors. I looked at several programs, and I looked at the length of time, honestly, the, the program would be, and also I looked at the cost, and I have two children. They're age now 11 and 13, and I'm really the primary person that takes care of them. I do all those school drop-offs and pickups, and I really wanted something where I didn't have to be away from them that often. And so I think putting all those things together with a program that was less than a year, actually, the University of Tennessee program was 11 months and was weekends, weekend sessions, 9 to 12, and my kids were sleeping. I think that was really helpful. And then there were some in-person, time also that allowed me to have networking and understanding of, really focusing on the education piece of it was important. But I think putting all those things together really helped me pick the program. Not to mention, I had a friend who did the program 2 years before me. And when I was trying to decide between the MPH and the MBA, he was like, you just have to do the MBA. And this program is the best one. It's supportive. And I think that's really where I thrive, is in a supportive environment that's not really cutthroat. And it was designed for physicians. And I really didn't want to be in an MBA program where I had a lot of like 20 and 30-year-olds who were, really knew a lot, like we're just in a different path than I was. And so I
Right.
think having a program that was directed to physicians was also very important to me.
Great. Well, this has been a great interview. I really appreciate you spending so much time sharing with the audience. I guess the last question that I would like to ask is there anything that we haven't really touched on that you think was critical or pivotal in this journey that you'd like to share?
I think, you know, I think the only thing I'd like to say is that as physicians, we often feel stuck in the roles that we're in. I have had, many physicians, men and women, reach out to me saying, we just feel stuck in where we are, and we don't know how to make a leap to go, to one, move to one thing. In fact, my husband even says to me, like, I could never do what you did. Like, I could never do all this. And and I think it's important for us to understand that like, we're highly motivated and highly educated, and we can make a change and we can explore different avenues. I explored many different avenues. I probably lost about 10 pounds when I left my practice because I thought like, I was like, what am I doing with my life? And then ultimately, even though I left practice, I, came back to it. And I think you can always come back to practice, but I think it's okay to explore different things. And we're not often taught that through our careers, that we can do something different and do something completely different and then come back.
Well, that's great. Well, again, thank you very much for joining us. We appreciate your time, and I look forward to talking with you again, especially getting some updates on how this practice develops and grows over the next several years.
Yeah, thank you so much for having me. I appreciate being here. It's been great.
Our second guest, who I'm equally pleased to introduce, is Dr. Luissa Kiprono. Dr. Kiprono is also an alumnus of the University of Tennessee's PEMBA program, graduating in 2020. Dr. Kiprono is duly board certified, completing her residency in OBGYN, followed by a maternal fetal medicine fellowship. She completed both at the University of Mississippi Medical Center. Dr. Kiprono is a physician leader, entrepreneur, founding 2 companies. She's also a motivational speaker and most recently an author. Luissa founded World Gateway Perinatal Consultants in 2018, and then in 2022 founded her most recent venture, Telemed MFM. Her new book is entitled Push, Then Breathe: Trauma, Triumph, and the Making of an American Doctor. I am really excited for you today to learn about Dr. Kiprono's work in telemedicine and the impact it's having on her life and the lives of her patients. Luissa, welcome very much to PEMBA On Demand.
Thank you, Norm. I am excited and honored to be the guest at the launch of PEMBA On Demand series. I am very, very happy to be an alumnus of University of Tennessee in Knoxville.
Great. Well, welcome again, and I'll let you move right into your presentation.
Okay. So, as Norm indicated, I am a maternal fetal medicine physician, completed my OBGYN residency, and I'm dually boarded in OBGYN and maternal fetal medicine. I am also the founder and CEO of World Gateway Perinatal Consultants, Telemed MFM, and recently Dr. Luissa K, the entrepreneurial and self-help, self-motivational program through my book, Push, Then Breathe. Next slide. So you may wonder how the journey all started. A decade ago, I finished my fellowship in maternal fetal medicine, and then I spent about 10 years in leadership, both in Southern Indiana and also in San Antonio, Texas. At the end of August 2022, when my former employer, Pediatrics Medical Group, closed down the practice in San Antonio, Texas, I arrived at crossroads. Follow the same path as I have for the past decade, sign another employment agreement, and just, do my job that I've been doing so far, or take the road less traveled and become a trailblazer for the present times. I choose the latter because I became exhausted really in investing in someone else's dream. So I decided to try something new, invest in mine. In between 2018, when I founded World Gateway Perinatal Consultants, which is the parent company of my organization, specializing in women health and international medical humanitarian missions, and 2022, when I launched Telemed MFM, and I completed my master's in business administration, physician geared and physician executive at University of Tennessee in Knoxville. Next slide. So what is Telemed MFM? Telemed MFM is a high-risk pregnancy care practice, which its broad vision is providing telemed solutions and access to maternal fetal care for all patients, regardless of geographical borders. We provide virtual consultations. We address delays in evaluation, assessment, plan, and treatment that presently we are facing with through the traditional also the referral processes that are at the present time. And our main goal to serve the underserved, the ones in the rural areas, keeping in mind that 99% of maternal fetal medicine specialists are practicing in large urban areas. Truly, the vast majority of our patients are in non-urban and rural areas. So, what my practice provides to medical organizations and hospitals is really to bring our location to their location and serve patients from afar and provide high-risk medical care to their unborn and to the mothers. Next slide. So you may wonder, how does this work? So there are opportunities and there are challenges to this. First, one should have a vision of whatever their project they have in mind, and really sit down and brainstorm, get a piece of paper, get a pen, and start writing down their ideas, provide themselves with a business plan, and also make sure that legalities are all taken care of, like medical licenses. Like myself, I have a medical license in multiple states. Medical liability insurance has to be taken care of, credentialing process, and so forth. Now, with the advent of the compact system, which is a more streamlined licensing program for physicians, it becomes slightly easier and more streamlined and faster on the licensing process. Unfortunately, not all states do participate, but most of them do. Least of them all is my location, obviously, because I am available everywhere through the virtual means, both synchronous and asynchronous audiovisual means that are encrypted from end to end, so they are HIPAA compliant. The other thing that you want to keep in mind, that once you launch your business, it's just not about just launching. You have to maintain it. Consistency and really self-discipline is very important in marketing. It took about 6 months to be able to take this business off the ground and start making it run smoothly. A lot of work involved, a lot of late nights and early mornings, and always, again, remember that marketing and having a business strategy and really communicate with everyone that is involved in every one of your clients or future clients is extremely important. Next, please. So what have I learned from this experience? I can tell you it's been both a experience that is scary and amazing at the same time. Founding a brand new practice in my specialty, Telemedicine FM, in my 50s, and not just any practice, it's a telehealth at the end of COVID pandemic and at the closure of my former practice that I ran for the previous 5 years. Well, it's been quite the ride. Additionally, it is the fact that it is my practice that I able to tailor to my clients and my patients' needs, and being able to do it in an efficient manner and a more patient-driven and referring OBs-driven rather than a corporate type of healthcare that we experience right now. The fundamental lesson that I want to pass to our physician listeners is to follow your heart's desire. Don't ever let anyone or anything hold you back from accomplishing your dream, whatever that may be, whether it's opening your own medical practice, launching a new business venture. If the idea to start something new and different is keeping you up at night dreaming about it, and it fills your eyes with sparkle when you speak about it, then it's time. So that, in addition, just a couple of months ago, I launched my second company, and that is in the advent of the publication of my book, my first nonfiction book, which is Push Then Breathe. And that is together with the platform that I am launching, which is the self-empowerment and self-help and thought leadership.
Well, that's very interesting. Thank you, Luissa, for sharing a little bit with us. As I listened to you talk, hundreds of questions came to my mind. But one of the first questions that I had, and this was even as we were talking about doing the live stream and bringing you on the show, is I guess I've never thought of maternal fetal medicine as a practice that was amenable to a telemedicine approach. How do you actually practice MFM without any direct patient contact?
So it's interesting, but I do get that question more often than not. So back in the days, when I say that, about 20 years ago, maternal fetal medicine physicians were, used to have their own prenatal care patients for high-risk patients. So really do prenatal care in their offices. And at the end of that period, 9 months, then those patients will be delivered by MFMs. It has been a change, and specifically in the last 10 years, because of the specialty. The specialty is quite young. It's about 30 years old. The problem where the conundrum that we are in, there are not a lot of us. There are about only 1,300 physicians, maternal fetal medicine specialists, out of which about 900 that are practicing full-time and boarded. So that against 370 million or so, American people, that is a very, very discrepant number, or ratio rather. So slowly the maternal fetal medicine physicians started to move towards a more consultative venue, allowing the OBGYNs who is really our specialty, initial specialty, let's call it, to provide medical care, prenatal care to their patients, and to also do deliveries, us being the ones who do consultations and co-manage. So imagine what we're doing today, talking to you and speaking with you, Norm, through the virtual means. And same way I speak with my patients, I consult. Everything gets done, like I said, encrypted. My system is actually integrated into the healthcare and hospital system I work with, just like I would be on site. That's how far we came along with the virtual and telemedicine or telehealthcare. Of our specialty. Again, the same thing. I go in virtually. I look at the scans. I write my reports, and if that is necessary at that time, I talk to the patients afterwards about any specific findings, and then I do a consultation and I render care. So really, the only two differences are that one, I am not in the same room presently, physically with the patient. A, B, that the pretty rather limited amount of procedures that we now do as outpatient, like CVS and amniocentesis, which are actually decreasing in numbers because of the advances in genetic testing, non-invasive prenatal testing, that is done by the physicians who are in person in the clinic at that time.
Okay. So it's been two things, a change in the way that MFM is practiced, plus an enhancement in the technology that you have available that has limited the procedural nature of the specialty, it sounds like.
Correct.
What about, so you mentioned that you work with a hospital system. Do you work with one hospital system or more than one?
At this time, I work at this particular time point in time. I work with one hospital system. They are a very large system in central United States in Kansas City, Missouri. I'm very proud and happy to say that they are an excellent system that I work with. It's St. Luke's health system, and the reason I work with only one is because I'm working really with them full time. So
Okay.
our relationship, our partnership is full time. So since right now it's just me because I really wanted to take this practice off the ground on my own and then expand as needed, but still stay small. That is.
Okay. What about how do you handle the patient billing? Do you directly bill patients, or does the hospital bill patients and then pay you on a salary basis or what some other type of basis?
Correct, the latter. So the hospital bills for the patient services and my services to the patient and to the OB providers and to the hospital. That is, initially established.
Okay. And what about participating with health insurance payers? Do you have to participate with the payers because you're providing care to their members?
Again, because the hospital does all the billing, I am credentialed, yes, with all the insurance companies that one physician will need to be in order for the hospital to bill. I am fully credentialed with all their payers, but through the
Okay.
hospital.
Okay. What about your liability insurance? You mentioned that you have liability insurance. Was there any issue getting liability insurance policies that covered you across multiple states?
That is part of the due diligence that I was talking about when setting up and maintaining a business like this. So I had to do some research. Texas Medical Association has a wealth of information, and even though this organizations may not be in Texas, TMA is since I'm a member, is actually very, very helpful in providing us with this kind of leads and links to be able to reach out to the insurance companies for medical liability insurance for the providers. Another thing I wanted to mention is even the insurance companies apparently are undergoing a transformation. So instead of just giving a physician a blank type of coverage for, let's say, the whole state of Texas or the whole state of Indiana, whatever state you'd like to use, they actually are becoming more streamlined. So they give you that for that particular organization or healthcare system, they will do the coverage. I believe in niche type companies and practices. I believe
Mhm.
that works a lot better, and it's really affordable. Because imagine if I would have to cover medical liability insurance over, a three-state area, even though I work in one state, or one whole state, even though I work only one organization. I think it's again, we are moving, and I'm very pleased to see that it's becoming like almost like a refined work of art. 10 years ago, I always said that it's time to move virtually and provide a smarter healthcare solution to our patients, far and far and wide. It's coming rather fast, and that's really the only good thing that COVID pandemic brought about. The fact that it just made us go and take a leap of faith and say, well, we can't do it this way. We have to reach our patient, and the patients have to reach us. So let's just you know put our thinking hats on and come up with something better, and we did.
What, as I was looking at your structure and you mentioned you have the parent company, what what services were you providing with the parent company that are different from Telemed MFM?
So again, the parent company, World Gateway, I opened it with the idea to create a nonprofit organization
Oh, okay.
for the humanitarian missions that I regularly undertake.
Mm-hmm.
Since 2011, I've been doing, actually take that back, 2008,
Okay.
and going into humanitarian missions to South America, Latin America, East Africa. So I wanted to launch this in 2018. Well, the cards didn't play well because in this favor, really to expand that foundation, mainly because at that time, because I was so busy with running the practice.
So did you then begin to, I guess I should just ask, what was the primary motivation then to form Telemed MFM? Was it to focus more on providing services within the U.S. in a different
Correct.
types of services? Okay.
Mhm. It's we have so much now. Somebody from East Africa will reach out and say, hey, I really need your services, which they do need our services, or if it's a maternal fetal medicine services.
Mm-hmm.
But there is so much need and so much work to be done here at home, that when I created Telemed MFM, my whole goal in mind is to provide these services here to our American, well, our native, let's put it this way, our native is not only American, it's everybody that lives in America, maternal fetal medicine on high risk pregnancy services.
So what do you see as the future for Telemed MFM over the next 12 to 24 months?
So over the next, so the short-term goal is to solidify, expand the services, have get aboard a couple more physicians who would be interested to work in this type of work. The telemedicine, it is, again, this practice is 100% virtual, 100% through telehealth. It does have a steep learning curve, and that is really one of my biggest reservations. Some specialties pick it up a little bit faster than others. I am, I'm very electronically savvy and I like to learn. I think curiosity, it's more than being electronically savvy. It's just, I want to learn. So I am very curious kind of individual. Um, a lot of physicians from different generations, for different reasons, they don't feel comfortable yet with the idea not being in an office, or not. If not that, is the technicality of it. Is that the technology, has to be embraced, and it has its quirks. But just like everything else, what I usually say, when the system is down in the up, and you have to update it and you have to upgrade it. The same thing here. I mean, there's no difference. You still have to write an electronic record, and you still have to look at the labs and the medical records through the computer. So you just have to we have to be flexible and learn. So I have to mindfully recruit this type of individuals who are interested to provide excellent medical care, who are boarded in maternal fetal medicine, and who are comfortable to do this through the Ethernet waves.
Okay, thank you. A question I have for you, I've talked to a lot of people about their decision to pursue an MBA. How did your decision to pursue an MBA fit into your vision for the entrepreneurial side of your career, speaking, leadership training, motivation, the non-for-profit? Can you tell us a little bit about your decision to pursue an MBA and what you thought it would add to your career?
Yes. So I'm a true believer that people change change gears, change interest through their lifetime and through their professional career as well. Um, I always wanted to be a doctor. Since I was in fifth grade, that was my, greatest dream, to become a doctor and help people. And once I achieved that, I, loved my job. I still do. I still love my job. But then I noticed that physicians are kind of sided when it comes to the business of medicine and the leadership of medicine. Much like, when we go into the C-suite, when we have a chair at the table, or a seat at the table rather, um, we are we want to feel like we actively are involved and into the decision making process. And it's not really said directly, but you could feel the shift in the room, that the physicians are on one side and the business people, or the suits as we call it, are on the other side. So this thought that when I started noticing that, I used to say to long time ago, I used to say, at least give us, the physicians, the illusion that we count. And I really mean that. I mean, don't just, we shouldn't be an afterthought. So at that time, I started thinking about getting an MBA. I have a vast experience in business and a business background. I worked in real estate for a decade, running a real estate company before I went to medical school. So I am very versatile in business. However, you cannot deny, that I did not have a degree, a diploma in business administration. So I started thinking about it. It started like a, thought. Then things got in the way, life got in the way, life, children, single parent. And then in 2019, if I want to do it and I really want to move on into the leadership role, and have a diploma to back, I should look to do an MBA. So I looked at MPH, which is public health research, versus an MBA, which has a exclusive leadership track. So I chose an MBA. Then I started looking more into it, and I said, well, I really can't do a 2 year. I could not see myself doing a 2 year program. So there were three things that, for me, those are three things that made my decision. I was looking at venue, time, and user friendly, being user friendly to me. And to me, time was of the essence. Where I was in my career, but also, age plays the factor. So let's just be honest here. And so I started looking at MBA programs that are not 2 years. And now, I can just give you my gist about why I chose PEMBA. So I looked at the program. I knew that I needed to have, a year program and not a 2 year program. That was very important. It was a lot of work, but it was more condensed. And how I used to say it, how I always say it, I don't like slow bleeds. Like, just let me do it. Let me do it my way. Let me do it fast and furious, and I'm okay with that. Second, I did not want to do a 2 year MBA. That was more generalized. I wanted to do a physician geared specialized MBA. So that really narrowed it down between those two. And then the curriculum format. Some of them do weekends only. Some of them do Friday, Saturday, Sundays. That some require a lot more commitment during the week. And I had a 52 people employee practice to run. So I could not afford to be away from the practice for long periods of times. So the way the format of the curriculum for PEMBA at the University of Tennessee in Knoxville, that was the perfect fit for me.
Great. Well, that is really helpful information. I always like to ask everyone who comes on the shows and my podcasts and the live stream, is there anything that we haven't really talked about that you would like to share with the audience before we close?
Yes. I want to first thank you, the university and the program, for allowing me to, come on this podcast and, this talk about how are we doing here as entrepreneurs, as innovators, as trailblazers, as my colleague, Dr. Rinku Mehra, and myself, chose to do. And then also to impart with you all that, it's as scary as it may be, you'd be surprised to see that there is a lot of support out there. People, all you have to do is ask for, have questions, be willing to be flexible, be willing to communicate, and there is a lot of people out there who will support you and will cheer you from from the sidelines, because what we do here, they do want to see more like us. They do, because it is more outside the square box, variety, change, and just moving forward, because we change all the time, and it is important to live, or walk with the times. We can just say, well, we've done it all this time this way. Why change? Well, we also used to use dial-up phones, and you used to use buggies to get to whatever we need to get. But that we're not doing that right now, and isn't that different? Yes. I think it's also better.
Yes.
So thank you.
Well, thank you very much for those final comments. It's been a great having you on the show, and I'm sure that the audience got a tremendous amount from it.
Thank you, Norm. You have a great day.
Thank you. You too, Luissa. So thank you for taking the time to join us on our inaugural Pemba On Demand live stream. We will be having more live streams discussing topics similar to this, relevant to physician leaders. We will also be releasing the content from the live streams as podcasts, and we'll be releasing additional podcasts bi-weekly. Information on the podcasts and how you can subscribe and access the podcasts will be available on the major podcast players such as Apple Podcasts, Google Podcasts, Spotify, Overcast, Stitcher, and Podcast Addict, for example. A very special thank you to Kate Atchley, Executive Director of the Healthcare Division of Graduate and Executive Education at the Haslam College of Business at the University of Tennessee, and to Dr. Don Leiter, Professor of the University of Tennessee and Director of the Institute for Healthcare Quality Research and Education, for both of their support for this program. Thanks also to Tom Brown, Sharath Shreeman, and Christy Napper. CME is available for the live stream. Visit tiny.utk.edu/Pemba On Demand to obtain your CME certificate, and we'll have this information posted in the notes as well on the YouTube channel.